In obstructive lung diseases like asthma, where individuals suffer from reversible narrowing of the airways, medications like bronchodilators are helpful in keeping the airways open. But most of the time, narrowing of the airways actually occurs as a result of inflammation and excessive release of various inflammatory chemical mediators like leukotrienes and prostaglandins. So to effectively manage the disease, it's important to give medications that will control the inflammation. So if we take a look at the lungs, you've got the trachea, which branches off into right and left bronchi, and then continues to branch into thousands of bronchioles. In the bronchioles, you've got the lumen, the mucosa, which includes the inner lining of epithelial cells, as well as the lamina propria, which contains many cells like the type II helper cells, B cells, and mast cells. Surrounding the lamina propria, there is a layer of smooth muscles and submucosa. The submucosal layer contains mucus-secreting glands and blood vessels. Now, the molecular pathway that leads to asthma is actually pretty complex, but it's often initiated by an environmental trigger. Allergens from environmental triggers, like air pollutants or cigarette smoke, are picked up by dendritic cells, which present them to a type II helper cell, or Th2 cell, in the lamina propria. These cells then produce cytokines like IL-4 and IL-5, which causes the inflammatory response. IL-4 is especially important because it leads to the production of IgE antibodies by B cells, and these antibodies bind to Fc epsilon R1 receptors on mast cells to activate them. These mast cells use an enzyme called phospholipase A2 to take membrane phospholipids and make a 20-carbon polyunsaturated fatty acid called arachidonic acid. Arachidonic acid is then metabolized by two important enzymes. One is cyclooxygenase 2, or COX-2, which makes prostaglandins. Another one is 5-lipoxygenase, or 5-LOX, which makes leukotrienes. Now, IL-5, on the other hand, activates eosinophils, which promote an immune response by releasing more cytokines that attract other immune cells to the area. Minutes after exposure to an allergen, phospholipase A2 gets activated inside the mast cells, which results in the synthesis and release of leukotrienes and the prostaglandins. Leukotrienes bind with the leukotriene receptors on the bronchial smooth muscles and cause them to contract. They also bind to receptors on the mucus glands to increase mucus secretion. Similarly, prostaglandins also bind to the receptors in the smooth muscles and mucus gland to cause a similar effect. These mediators also increase the vascular permeability in the airways and attract more immune cells to the area. The combination of inflammation and bronchospasm cause obstruction of the airway, which leads to symptoms like coughing, chest tightness, dyspnea or difficulty breathing, and wheezing, which is a high-pitched whistling sound during exhalation. Chronic inflammation also makes the respiratory tract more sensitive to allergens, so these symptoms become easier to trigger. Now, we have 3 ways to control the inflammation in asthma. We can decrease the synthesis of inflammatory mediators, inhibit their release, or prevent mast cell activation. The most common way to stop the synthesis of prostaglandin and leukotriene is through the use of corticosteroids. These medications are synthetic versions of glucocorticoid, or cortisol, which is the stress hormone produced in the adrenal cortex. When these medications reach immune cells, they can pass through the cell membrane because they are steroids, which means they are lipophilic. Once inside, they inhibit the synthesis of all inflammatory cytokines. In mast cells, they increase the production of annexin 1 proteins that inhibit the enzyme phospholipase A2. This stops the conversion of membrane phospholipid into arachidonic acid and decreases the synthesis of leukotrienes and prostaglandins. Corticosteroids also downregulate the enzyme cyclooxygenase 2, which reduces the production of prostaglandins. Finally, they also inhibit the proliferation of the Th2 cells, which reduces the production of IL-4 and IL-5, further reducing the activity of mast cells and eosinophils. This way, corticosteroids effectively inhibit the inflammatory process at multiple stages. Depending on the route of administration, corticosteroid therapy for asthma can be divided into 2 broad categories: inhaled therapy and systemic therapy. Inhaled therapy uses nebulized corticosteroids, which means it's an aerosolized mist. It's the first-line therapy for chronic asthma because its action is localized in the lungs, so there's fewer systemic side effects. Inhaled corticosteroids are often used alongside a bronchodilator like leukotriene receptor antagonist or a beta-2 agonist to control the disease more effectively. Fluticasone, Budesonide, beclomethasone, dexamethasone, and mometasone are some of the commonly used inhaled glucocorticoids. Among them, dexamethasone and fluticasone are the longer-acting and more potent medications. Systemic corticosteroid therapy is usually given when bronchodilator therapy and inhaled corticosteroid therapy fails to control the symptoms. In general, prednisolone is the medication of choice. Oral prednisolone is used to treat the symptoms of severe chronic asthma, while intravenous prednisolone is used in acute asthma attacks. Systemic side effects of corticosteroids include susceptibility to infections, growth retardation in children, easy bruising, hyperglycemia or high blood sugar, and weight gain. These side effects are less common with inhaled corticosteroids unless they're used at high doses. However, inhaled corticosteroids weaken the immune response in the mouth and throat, which makes oropharyngeal candida infections more common. Mouth rinsing after using the medication, or using a spacer, a device that allows the medication to enter the back of the throat slowly, so most of it goes to the lungs, can be used to prevent this complication. Systemic therapy could cause pituitary adrenal suppression, where less cortisol is produced. So when it's time to stop treatment, it's important to reduce the dose gradually to give the adrenal gland time to ramp up cortisol production. Moving on, the next group is the mast cell stabilizers, like cromolyn and nadocromil. These medications inhibit the release of prostaglandins and leukotrienes from mast cells. They're usually administered as an aerosol through an inhaler, since they are not well absorbed in the GI tract. Once inhaled, they act locally and stabilize the mast cell membrane, which prevents the release of inflammatory mediators. This way, they produce a mild anti-inflammatory effect at the site of inflammation. Mast cell stabilizers are usually very safe and well tolerated. That's why cromolyn was used as a long-time prophylactic medication for mild to moderate asthma. But, compared to inhaled steroids, mast cell stabilizers have a very short duration of action, which is why they're rarely used nowadays. Finally, the last medication is the anti-IgE antibody omalizumab. It's a modified monoclonal antibody that is administered by the subcutaneous route. Omalizumab binds to the IgE antibodies in the bloodstream, so they can't stimulate the Fc epsilon R1 receptors on mast cells. This decreases the activation of mast cells, which in turn reduces the synthesis and release of various inflammatory mediators like leukotrienes and prostaglandins. Omalizumab's main drawback is that it's a very expensive medication, so it's typically used if the person does not respond to other medications. It's particularly effective in treating allergic asthma, which often presents with very high levels of IgE antibody. Side effects are usually mild and include susceptibility to infections, as well as pain, redness, and swelling at the site of injection. We want to make a simple and fun mnemonic that'll help you efficiently memorize and retain all these pharmacology facts. Let's start with a sailboat with a large mast for mast cells. On the bow of the ship is our corticosteroids. Since they all have son in their name, let's use a group of boys to represent them. First, let's have two of the boys doing math problems on a whiteboard for dexamethasone and beclomethasone. The mother is there playing the flute for her sons, which represents mometasone and fluticasone. Lastly, there's a pair of conjoined twins who are best buds for budesonide. They're surrounded by a misty fog to help you remember that they are inhaled corticosteroids. Next is a boy dressed as a shark, the most fearsome predator of the sea, for prednisolone. In the shark costume mouth is an IV bag to help you remember it's a peroral or intravenous medication used for systemic treatment. For side effects, let's have a candy mushroom by the inhaled corticosteroids, since they cause oropharyngeal candidiasis, which is a fungal infection. For systemic side effects, we have a tiny elf for growth retardation, and he's eating handfuls of sugar for hyperglycemia. This makes him kind of fat, representing weight gain, and he bumps into things a lot, so he's got a black eye to represent easy bruising. For the next group of drugs, let's look at the middle of the boat, which is full of holes. These holes allow inflammatory mediators to be released from the mast cell. So let's put 2 chrome plating over these to represent cromolyn and nadocromil, the 2 drugs that block mediator release. However, they're nailed rather poorly, and it looks like they're about to fall off. So remember, they are very short-acting and therefore rarely used. Finally, at the prow is the engine that starts or activates our mast cell boat, but resting on top of it is a lizard with an omega sign on its back for omalizumab. This lazy lizard is preventing mast cell activation, and it's sneezing uncontrollably to help you remember it's very effective in allergic asthma. He's resting on top of a pile of cash because this drug can be very expensive. On his rump, there's a big red bump with a band-aid on it to help you remember there can be a painful swelling at the injection site. Alright, as a quick recap. Treatment of asthma involves stopping the underlying inflammatory process by reducing the release of inflammatory mediators like leukotrienes and prostaglandins. This is done by using corticosteroids, which stops the synthesis of these mediators, mast cell stabilizers, which inhibit mediator release, or anti-IgE antibody that inhibits mast cell activation. These medications are typically used alongside bronchodilators for asthma prophylaxis. But wait, there's more! Here's a mind map with all the mnemonics. Go ahead and pause the video so you can test yourself to see what you remember. And stay tuned for the answers after the credits.